talked about matter in the areas that we've talked about them in, such as patient and doctor relationship, legal and policy factors, and medical technologies and protocols, because these are the tools that terminally ill patients have to access dignity in clinical situations, not just in theoretical or academic situations that we create. These are the tools that patients actually have to use to improve their dying process, and if not improve their dying process, change it. And so these tools also give more credence and support to die in a way that gives patients peace and gives credit to how they lived. Dignity is a very subjective thing, but the way that we deliver it to dying persons doesn't have to be subjective. We can actually have very tangible tools to deliver it. All right, do we have any questions? Also, this is, since that was a really heavy topic, here's my emotional support animal for all of you. So,
so one, thank you for your presentation. It was really great. I know over the past few years you were doing different research methods, and so it looks like you finally did a literature review to narrow down the 3 advocacy groups.
I like it
yeah. So how did you choose to go that route, and why?
So there are, the more that you dig into this field, the more that it just kind of unravels as being this just huge rat's nest of different issues, different social problems, human rights issues, medical technology, medical college education. There's a lot of different factors that run around in this field that any one of them is important. Any one of them can be picked apart, and it became a question of which area is attacking the most amount of factors and how are they actually influencing change in the field. Because the real question here, and you saw in the research question, is what is the change over time and how are things improving and how are we going to keep improving? Advocacy groups ended up being the answer to that question, and they sit right in the middle of not all of the different factors that run around in death with dignity practices, but definitely right in the center of some important ones. So that's how we ended up here. They kept being the line, when you start pulling apart those threads, it kept coming back to these groups. So. Thank you. Jakob?
So you told us kind of what you think should happen, right, in this area. This might be outside the scope of the study kind of thing, but just if you get to speculate, what do you think is going to happen in the future?
So if I had to speculate, I would say that Death with Dignity Acts are going to continue to be passed, but that they're not going to pass cleanly and easily, because we can already see in some states, Washington had a piece of legislation that went forward, and their Death with Dignity Act has been in practice since 2009, and it was directly modeled after the Oregon Death with Dignity Act, which has shown extraordinarily good compliance and success in its existence. So in theory, the Washington Death with Dignity Act should have worked the same way and been easy to operate with, I'm going to say easy, but doable to operate with. But there was a piece of legislation that just got pushed forward, I think in 2017, trying to mandate that doctors, kind of the complete opposite of the Palliative Care Information Act, mandate that doctors communicate curative options to people who are asking for the Death with Dignity Act, because they obviously have to go through their medical doctors in order to use that system. The court, that was, I can't remember where this was happening, I think it was actually in Congress in Washington, but they were trying to push that when patients ask to pursue the act, that the doctor has to have a conversation with them about possible curative options, and I thought that was ludicrous, because at that point, is it really medically ethical to tell people that there are curative options? But I think that there's going to be a lot of contention like that moving forward, where 2 steps forward, maybe 1 step backward, but that this will continue to get passed. And I also think there will be more adoption of it, because it seems from the literature that there is a lot of covert usage of physician-assisted dying, and there's a lot of medical willingness to assist in that, because doctors have that clinical side point of view that other groups don't have, where they see people suffering and they see how emotionally effective it can be, and it really wears on them too, so they want to help facilitate it. I think that these acts will actually be adopted when they happen, because that's already happening. It's just going to move out into the open. But there will always be legal battles. There will always be the opposing point of view. So, yes.
So I know a few of the advocacy groups that you looked at were patient-centric, but I was wondering if you found within those advocacy like
That is
lead
the-
them ahead of their narrative, you know.
That is the main vector of advocacy, outreach work. Thank you, ladies. She's going to her own defense. She's helping someone. But that is actually the main thing that Compassion in Dying uses to communicate their points of view. They are constantly using clinical cases and patients and being like, let's call her Margaret. She dealt with this disease. This was her familial situation. It was happening in this state. This was the advancement of her symptoms. This is everything that we tried. And then she asked for the assisted dying, or she asked for maximum pain dosage, whatever argument they're trying to advance. They use that actual patient case and say what happened, how it happened, and what the alternative could have been had not she entered into an advocacy group situation. So they do often use personal testimonies, and they don't just use it from the point of view of the advocacy group telling. They actually have documentaries and stuff with family members and other, it's usually not terminally ill people because they are kind of in a critical state. They're not hanging out for documentaries usually, but the family members in the aftermath oftentimes are interviewing and speaking about this. So these groups do really actually heavily use that. And when I say patient-centric, it's like, it's a good thing to be patient-centric, but it's not a good thing to put doctors at risk and say that, or to assert that doctors should do things that are illegal just because it's what somebody who is dying is asking for. Like, yes, we might agree with that, but also you're putting somebody else at risk as well there. So that's what the patient-centric thing is, positive and negative because of that. But that's for later groups, not so much the Hemlock Society, but later groups did use that very heavily with the personal testimonies. So it was very effective. Mm-hmm. Christian.
So these degree conceptualizations pull out from all these advocacy groups that you've looked at.
Mm-hmm.
And these advocacy groups seem to be, I think it's fair to say, they're committed to death of dignity being pursued in the medical and legal systems in particular ways.
Mm-hmm.
To what extent do you think that these similar kinds of conceptualizations are present amongst doctors, amongst patients themselves, amongst legal scholars, other areas that seem relevant? Again, this is speculative. To what extent is this advocacy group specific conceptualizations versus more general ones?
So I would have to say that more general ones would be the doctor is the ally of the patient. I think that in the medical community that can be pretty much expected. There are always outliers, of course, in every situation, but I think that the doctor being the ally of the patient is pretty generally applied, but also that interaction and that allyship could be maybe not fully facilitating patients' wishes. So there's like bits and pieces. I would say that for some reason you would think that this would be a more obvious thing that people accept and use on a more wide medical platform, but I think that curative treatments are still, if we had to say in a broad scope of the US, that curative treatments are pushed before comfort treatments in the case of people who are dying. And that's not just on the case of the caregivers, that's also on the case of the person who is dying, especially a big faction of this that needs to be touched on is like breast cancer. What about like moms who are, or like women who are young-ish and they're like moms to little kids, they have families relying on them, like there's going to be a fight until the end usually in those cases. And so hospice isn't really always an option for people because giving up, or not giving up, but yielding to the disease isn't an option. And then grief improvement, that's, believe it or not, something that's even still being implemented as education in medical systems or medical schools for bedside manner. That's still something we're all working on. And then this I think is getting better, definitely. I think this is more generally accepted, using pain management in these cases because we have even created technologies. I didn't touch on it in this presentation because we only have so much time, but patient-controlled analgesia was developed in the 90s, and that's an important one where you hook up the IV to the body and you have pre-dosed packages of the pain medication ready to go, and the person